When patients are diagnosed with metastatic clear cell RCC, first-line treatment typically consists of a PD-1 checkpoint inhibitor, either combined with a CTLA-4 checkpoint inhibitor, kind of dual immunotherapy, or combined with an angiogenesis-targeted therapy. When patients experience disease progression on a PD-1 checkpoint inhibitor, the ESMO guidelines and other consensus guidelines recommend one of many different angiogenesis-targeted therapies. Now, there's 5 to 7 different options that are typically listed for someone to choose from, and there's not a lot of clarity about which treatment we should be using. Most of these agents were compared against older historical controls and have not been compared against the contemporary agents that we're using. So the LenCabo study was aiming to test the hypothesis that lenvatinib plus everolimus, since it's combining 2 different distinct mechanisms of action, would improve progression-free survival compared to cabozantinib after progression on a PD-1 checkpoint inhibitor. That being said, the primary endpoint was progression-free survival for our study, and lenvatinib plus everolimus significantly reduced the hazard for disease progression by 49% compared to cabozantinib. This result was statistically significant with a p-value of 0.02. The median progression-free survival was 15.7 months with lenvatinib plus everolimus versus 10.2 months with cabozantinib. We looked at some other secondary efficacy endpoints. We looked at objective response rate by RECIST. The objective response rate with lenvatinib plus everolimus was higher than cabozantinib, 53 versus 39%. There was very low primary progressive disease irrespective of whichever treatment you received, but that difference in objective response rate was not statistically significant. Finally, we did evaluate overall survival, but this study was not designed statistically to test overall survival, and overall survival is very immature. There's only 20 or 24 events of the total of 86 patients, which is great for our patients, but is ultimately it's a very immature analysis. That all considered, lenvatinib plus everolimus was associated with a 5% increase in the hazard for death compared to cabozantinib. The 95% confidence intervals were extremely wide, both compatible with a lot of benefit from lenvatinib plus everolimus or harm coming from lenvatinib plus everolimus, so just inconclusive.